to our next session, that is session 5 on treatment of Mazdaldi first. And for this, I am deeply honored to invite on a stage as the chairpersons Dr. Zubair Yunusi. Sir, please join us on stage, sir. Dr. Punita Tandon and Dr. Deepika Kedia. Dr. Zubair. Over to the chairpersons, inviting the speakers. Thank you.
Okay. Thank you, everyone. So, opening session 5, I'd like to invite Dr. Gurdas Chowdhury, who's going to speak to us about improving outcomes in MASLD with lifestyle interventions.
Good afternoon. I bring you greetings from Delhi. I've been involved with this topic for quite some time. And specifically, I think most of what I'm going to say is more or less known to you, but I'll put them in the form of questions and answers. Okay? So, do lifestyle changes work? Is the easiest thing we talk about. And what is exercise and diet, and what are their respective roles? I think most of us have now come to agree that this present epidemic of MASLD is related to an imbalance of the calories that get into our body and what we are able to burn. And that's why the extra calories pile up as triglycerides get accumulated in the liver, and that causes problem. The question that is here is lifestyle alteration, does it work in reversing MASLD? So is it possible to use it as a therapy in patients given the large numbers that were talked about? What's the relative roles of diet and exercise and others? And what are the hurdles then? If suppose this treatment is indeed so simple, why is it such a major hurdle that most of us, I guess even in the medical profession, we seem to be suffering from MASLD? In fact, I was in a conference in Goa last month, and they happened to do liver fibro scans, and the data was that 60% of the doctors in Goa actually had fatty liver disease, and they were doing it for the common public. And if these barriers and hurdles are known, how to overcome at least some of them? So weight reduction, diet and exercise hold the key. So we did our little studies way back in, that was 2006 when I was at the Sanjay Gandhi Institute. And this topic was relatively new, and we got a bit intrigued to see how it works. So we invited patients of fatty liver disease coming to our clinic to come and participate in a study. It was a prospective lifestyle intervention study. No liver biopsies initially, but we were keen to see what happens and what does not happen. Okay. Most of these people were, by the way, from the administrative department of our hospital. So, you know, they're basically sitting on their desk and they don't do much of exercise. So at that point in time, 2005 or 6, we put them through a fairly straightforward diet and exercise regime, slightly calorie restricted diet, aerobic exercise, 45 minutes a day to achieve a heart rate of 60 to 70% of their maximal heart rate. We got professional trainers. We used a handband to make sure that they reached the right amount of heart rate, kept it there for 25 minutes. Fairly simple, actually. And of course, we had music to make it more entertaining. Otherwise, you know, just doing exercise for 6 months doesn't make sense. So the studies were simple. So the question was simple and the answers were also simple. So of the 90%, 90 people who participated, 60 went on for the study. And these are the response of liver enzymes. So those who had elevated liver enzymes, who were a little heavy, their liver enzymes steadily declined with a diet and exercise regime. And in any lifestyle intervention study, there will be the procrastinators who intended to join but couldn't actually come. So they were the ones who did not improve. So that's the line there. We calculated what happened pre, post, BMI, waist hip ratio, and so on and so forth. But that's, you can more or less understand what it would show. The important issue was that was a time when we were talking a lot about insulin resistance as being the underlying cause for fatty liver disease. So we used a fairly old-fashioned scoring system called the HOMA score. And you see most of the patients had elevated HOMA scores. And the ones who participated in the diet and exercise program, their HOMA scores declined over 6 months. The procrastinators did not show that response. When we sent this paper for publication, we had quite a few, but one paper that we sent to an international journal. So they reminded us, look, you started off with fatty liver disease. You talked about HOMA, you talked about liver enzymes. What happened to the fat? So we actually managed to have some patients who agreed to provide paired liver biopsy samples. So one was done at the initiation, and a few patients after they had done extremely well. So this is the fat in the liver before we started, and this is the fat in the same patient after 6 months when he had improved, lost weight, and the liver enzymes had gone. So this was more or less a proof of concept study, and we were not the first, by the way. There were quite a few studies also, which showed that yes, life and lifestyle alterations, so if you get back to exercise and cut down on calories, it does improve fatty liver disease on all aspects, okay, including liver histology. So this was 2013. After that, there were a lot of other disturbing questions coming up. What type of diet should you have? What's the role of diet versus exercise? Which type of exercise? Naturally, very interesting questions. Who should lose weight? So, I think let's cut the whole thing very simple. Diet is very important in order to lose weight. So, if anybody has got a high elevated weight, he can't probably achieve too much only with exercise. He needs to cut calories. And there are two broad types of diets. So there are about 30 of them on the social media right now. So one is to change your food type or quantity. So it's calorie restricted, what you eat, what you don't eat, so on and so forth. And the other is called a time restricted diet. So this came from one of the studies done in the 70s, which showed that lean mice who were fed peanuts only once a day went on to live longer and had more energy than the ones who were given peanuts all through the day and who became obese. And that's what fatty liver is all about. So we were at that time a little fanciful and looked at what happens to different types of intermittent fasting. So, the commonest one is 16-8 fasting, and there are, of course, the alternate day and the 5-2 types. But suffice to say that some type of fasting where you fast for at least 15 to 16 hours leads to a metabolic switch in which the calories that are required, instead of using the sugar and the starch in the liver, it goes on to burn fat which is stored in the liver. And that's why this was that time very popular. And in fact, there were very elegant studies which showed that liver fat did regress in patients who were on some kind of intermittent fasting. This was the paper which came in NEJM. Most of you might have read about it. What were the hurdles in intermittent fasting? Oh, by the way, intermittent fasting is also ritualistic fasting. For those of you who are interested, the blue zones in the world, 6 of them, the latest to be included is Singapore, which is an educated blue zone area. All of them have intermittent fasting. But nevertheless, the hurdles were our concept of 3 meals a day. So if you don't eat a meal, something has gone wrong. Meal modifications may be difficult in diabetics. Certainly, they have a very thin balance. And controlling hunger for the first few days. So now what kind of diet? So every other day in a meeting, we hear of a fanciful name. I think the last 6 or 8 years, we have been hearing about Mediterranean diet. I think even in non-Mediterranean countries, we are forced to sit up and think about how to make it an Indianized version of a Mediterranean diet. But now the Eat Lancet reference diet and so on and so forth. Now, of course, when I talk about diet, I must mention that the main constituent of diet, which has come under firing by scientists, is actually the sugars and the starch. And I am particularly not resentful, but mindful, because I'm a Bengali and we love our sweets. But nevertheless, fructose and sucrose are supposed to be the main culprits, and then comes starch. Coming to exercise, we used aerobic exercise in our study. Thereafter, people have tried other forms of exercise, including strength training exercises. And the end result is that both of them seem to work. So when you have a controversy as to which one is better, what do we do as scientists? We do best. We say combine both of them. So a good bit of aerobics with a little bit of strength training, because yes, strength training helps to build muscles, and muscles have become a very important endocrine organ of the body, which helps in energy metabolism. The pathways, how the two types of exercise work, similar but somewhat different, but nevertheless, those who are interested can go into it. What about high intensity exercise versus moderate intensity exercise? I think you'll be surprised. Almost any type of exercise works. And there are weekend warriors in today's world who would go to the gym 2 days a week, but even they seem to be doing well. And you can't leave a discussion, leave yoga out of the discussion in India. So there are at least 20 eligible studies which looked at yoga. And interestingly, 19 of them showed that there was an improvement in HbA1c and glucose metabolism. So what exactly then are the hurdles with exercise? So if everything is so simple, diet and exercise, what are the hurdles? So if you look at the barriers to exercise, so one is, of course, the physical and mental reason. Energy requirement, some people feel a lot of fatigue. There is a lack of enjoyment. That's why we actually played music for our patients. Lack of knowledge. Some of our politicians feel if they look very thin, they won't get votes. It was very interesting in UP. I think we associate a chubby figure with authority, the old time movies, and the lack of support from family and so on and so forth. So today, the question is, the problem is a huge problem. The solutions are not very difficult. Lifestyle modification is bound to help, given the huge number of patients whom you can't either do your NIT or your biopsy or your therapy with pharmaceutical agents. But the problem is with what we have been conditioned to be. And I keep asking people, if somebody comes home as a guest, what would you offer? So they would either offer a syrupy cup of tea or a coffee in India. Nowadays, that has been replaced with a little bit of beer or something else, with some cookies, which are always very sugary, and otherwise samosas and jalebis, which have come in for a lot of political controversy in India. I hope all of you know that. And the problem is the temptation versus motivation. So in motivation, how do you motivate yourself and the community to do well? There are broadly two types of people. One are the self-motivated loners who would get up in the morning. I see it in New York every time I go there. They would get up at 6 in the morning and run. I mean, aimlessly or otherwise, but they would run. I quite appreciate them, admire them. And there are many who like to do group activities. So unless they're in a group with other human beings around, they generally don't enjoy the process. And some don't like exercise. They like exercise with entertainment. Those who like to play games like a squash or a tennis or a shuttle. Whatever it is, we need to be able to get active. We need to redefine what is smart appearance. It matters. Okay, and we have to be able to be mindful about what we eat. And the solutions are not all that difficult, and so many biopsies won't have to go there. Thank you so much for your patient hearing.
Thank you, Dr. Chaudhary. That was an excellent talk, and we all know that it's very difficult to get our patients motivated to continue exercising and losing weight. Our next speaker is Dr. Shalimar. He's going to talk on vitamin E, saroglitazar, and other PPARs in MS-ALD.
Okay, so my task is to talk to you about the role of vitamin E and the PPARs. Gained significance because of saroglitazar, which is available in India. So let's look at what is the data. Okay, so what are PPARs? PPARs are peroxisome proliferator activated receptors. These are ligand activated transcription factors or nuclear hormone receptor superfamily. They are differentially expressed across tissues and play a key metabolic regulators in liver, skeletal muscle, and adipose tissue. They regulate lipids and carbohydrate metabolism, inflammation, and fibrogenesis. A busy slide. I just want you to focus on that PPARs are alpha are mainly expressed in the liver, play a role in fatty acid oxidation, have a regulatory effect on lipoprotein synthesis, inflammation, and insulin resistance. PPAR beta, expressed in skeletal muscle and adipose tissue, enhance the fatty acid oxidation, and PPAR gammas are in the adipose tissue, energy storage, and aggregate lipids. Based on each of these receptors, agonists have been developed which have been tried in NAFLD or what we know as MASLD. These could be either single receptor agonists, that is at alpha, beta, gamma, or they would be at dual. That includes the saroglitazar, the thiazolidones, alafibranor, and the latest one on the block is the lanifibranor. Let's go through the data of each of the clinical trials which have been published. This was a trial on rosiglitazone for biopsy-proven NASH, randomized control trial, 32 patients treated with rosiglitazone versus 31 treated with placebo. What this study clearly showed was that there was a significant improvement in the steatosis and the transaminases with rosiglitazone. But there was no improvement in other histological features, including fibrosis. This was the initial study published on pioglitazone for NASH in patients who had either impaired glucose tolerance or had type 2 diabetes. This was again a randomized control trial, a proof of concept study, included 26 patients treated with pioglitazone and 21 with placebo. Data showed very clearly that pioglitazone had a significant reduction in the liver fat, ballooning, and inflammation, but there was no change in fibrosis. Thereafter, a very elegant, well-designed study, which is the PIVENS trial by Professor Sanyal and his group, compared pioglitazone versus vitamin E versus placebo. Vitamin E, as we all know, is a peroxyl radical scavenger with antioxidant, anti-inflammatory, and anti-apoptotic properties. It reduces de novo lipogenesis. The study included patients with biopsy-proven NASH without diabetes. The data showed that vitamin E was better than placebo. Pioglitazone did not show any benefit over placebo in terms of the primary outcome, which was change in the histological features. Interesting again that there was no change in the fibrosis. But important data came on the secondary endpoints in terms of pioglitazone showed that there was a improvement in the definitive NASH compared to placebo. This was followed by This study also showed that pioglitazone and vitamin E both led to a reduction in liver enzymes, and important to state out here that the side effect of pioglitazone was an increase in weight, which was seen over here to the count of almost like 2.5 kgs in contrast to the placebo and vitamin E. This was followed by another study which compared a combination now, which was with vitamin E and pioglitazone versus vitamin E and placebo. This study included patients with type 2 diabetes, in contrast to the earlier study, which included patients without type 2 diabetes. The primary outcome of this study was a reduction in 2-point score in NAS score. The data from this study showed that a combination of vitamin E plus pioglitazone compared to placebo improved liver histology in patients with NASH and type 2 diabetes mellitus. Vitamin E alone did not have any significant change in the histological outcomes. There was no change in the fibrosis in either of the two arms compared to placebo. Similar study in the pediatric population comparing vitamin E to metformin in adolescents and children with non-alcoholic fatty liver disease, as the term was known in those days. The primary outcome was sustained reduction in the liver enzymes. This was a negative trial in terms of the primary objectives of the study, but the secondary endpoint showed increase in resolution of NASH in patients who received vitamin E in contrast to placebo. A recent study from China, 124 patients randomized to vitamin E versus placebo, biopsy proven, showed some improvement in the histology, 29% versus 14%. Important to note that this whole study didn't show any difference in the MASH resolution or any resolution in the fibrosis. Vitamin E also has gray areas. There is still a concern about the dose escalation, about safety concerns including hemorrhagic strokes, prostate cancers in male, cardiovascular disease, and all-cause mortality. Coming to the drug, which is now approved in India, which is a dual PPAR agonist, saroglitazar. This data comes from Professor Naga Chalsani's group in United States. Patients with NAFL, this is not a biopsy-proven cohort. NASH defined as ALT more than 50, BMI more than 25, randomized into 4 groups, saroglitazar 1 mg, 2 mg, 4 mg, and a placebo. What this study showed is there was a reduction in the liver enzymes over time, with the marked effect being with saroglitazar 4 mg in contrast to the rest of the other doses and placebo. What this study also showed us that on MRPDFF, there was significant reduction in the fat in the 4 mg group compared to the rest of the 1 and 2 mg groups. Saroglitazar also showed a reduction in the lipids in terms of cholesterol and triglycerides, helping in the dyslipidemia in these populations. Important here to note, there was a gain of 1.5 kg of weight with 4 mg saroglitazar compared to 0.3 with placebo. We do not have published data on histological endpoints with saroglitazar as yet, and we look forward to that data over time. In the meantime, another drug, which is a dual PPAR agonist, alafibranor, this study, randomized control trial, with 80 milligrams and 120 milligrams of alafibranor showed promise, was published in 2016, but the phase 3 trial was stopped in between as it did not achieve a statistically significant effect on the primary endpoint of NASH resolution without worsening of fibrosis. The pan-PPAR agonist, lanifibranor, in this trial, two doses, 800 milligrams and 1200 milligrams, were compared to the third group of placebo, and a standard primary endpoint in this study was a reduction in more than 2 points in the SAF score, which includes steatosis, activity, and fibrosis, showed that there was significant improvement in the primary endpoint with the 1200 milligram dose of lanifibranor. There was significant improvement in the NASH resolution, and more importantly, this study also showed us that a composite secondary endpoint, that is, a resolution of NASH and an improvement of one stage of fibrosis, was achieved with this drug with both 800 milligrams and 1200 milligrams of lanifibranor. Important here to note, there were some side effects: diarrhea, nausea, peripheral edema, anemia, and weight gain, which occurred more frequently with lanifibranor compared to placebo. A recent study published this year of use of lanifibranor in a small randomized controlled trial in patients with type 2 diabetes and MASLD showed an important benefit. In terms of what this study showed is lanifibranor was associated with a reduction in the intrahepatic triglycerides, reduction in hepatic insulin resistance, adipose tissue insulin resistance, and then reduction in muscle insulin resistance, thereby highlighting its possible role in improving the metabolic dysfunction in patients with MASLD. Coming to my last two slides, this is a very recent systematic review and a network meta-analysis which essentially compares all drugs which have been used for studies in which liver biopsies have been done, that is paired liver biopsy. So we look at what we are looking at from the regulatory point of view, either is MASH resolution or resolution of fibrosis. This network meta-analysis showed that lanifibranor, pioglitazone, and vitamin E plus pioglitazone do perform better than placebo for MASH resolution, whereas elafibranor and vitamin E alone do not perform well related to placebo. And when you look at the fibrosis improvement, that is one stage of fibrosis, none of the drugs which I have talked about, that's the PPAR agonist or vitamin E, are helpful in improving the one stage improvement of fibrosis. And when we look at even the Sukra ranking, which is how a drug performs when compared to the rest of the other drugs, they really perform really poorly for fibrosis improvement, whereas for MASH resolution, definitely they do perform well. And so, ladies and gentlemen, to conclude, vitamin E, the data suggests definitely there is some benefit in terms of resolution of steatohepatitis, but it doesn't support the resolution on fibrosis. PPARs are promising. They do have some adverse effects. Combination therapy, possibly that's what we are looking for in the future. We need more data in terms of randomized controlled trials to look forward to how these drugs are going to span in terms of the clinical landscape for management of patients with MASLD. Thank you.
So we're going to go ahead and actually open both presentations for questions. Maybe I can ask the first question of Dr. Chaudhary. When you're looking at sort of lifestyle, is it the composition of diet that's important, or is it the reduction in calorie? Which one is more important?
I think composition is very important because it's very difficult to just quantify or reduce one particular thing, like say sugar. If you take enough of it or less of it, it doesn't matter. You actually have to have the fiber as well, because your glycemic index and so many other things would depend on it. So that's actually the part that one would have to tweak in terms of the diet per se, rather than just the constituent. And that's why Mediterranean diet has become so popular, and so are all the new diets which are coming up. There has to be a balance, but the focus in what you need to cut down has to be fructose, sucrose, and starch. And those are the three which seems to be the main.
Excellent talk. I'm Dr. Ashish from New Delhi. So my question is to Dr. Chaudhary. So you had a cohort of subjects who exercised in your supervision. So my question is, what happened to them after the trial ended, since they were your employees and from SGPGI? So what happened to them after maybe 6 months or 1 year later? Did they continue to exercise, or then they stopped it?
What's your guess? Ashish, you were
Stopped.
also in the same institute.
Stopped.
So I'll tell you,
Stopped.
people stopped at different stages. Some of them felt so well, they decided to continue, but I must admit they were a minority. Many of them went back to their good old ways and therefore again had weight gain. But having said that, I'll say the same applies to almost all the therapies that you're talking about. So the last but one slide which I showed was motivation. So what one needs to actually encourage people to do is to keep your motivation up. Last week I had a patient who had lost about 15 kg of weight 4 times in her life. So every time she lost, she picked it up again. Obviously you realize she was a moody girl, and that's the reason why it was fluctuating. So somewhere along the way, you can't de-link this physical part with the rest of it, your attitude.
Thank you.
Next question.
Can I, sir? Go for it. Dr. Shalima, excellent talk as usual. Multiple drugs are in pipeline coming up. You discussed about the 3 of them. Vitamin E is not considered to be too good for a long period of time. You say it, right? Everybody says that it is for steatohepatitis improvement, not for fibrosis. And for fibrosis, we say the PPAR has got some amount of promising results. Do you advocate giving both at the same time? And for how long? Because we don't have an endpoint.
So, sir, if we look at the individual data, so PPARs, which ones are we looking at? The one which has been shown to have reduction in fibrosis is only lanifibranor. So we still need more data on that drug regarding whether it's going to really translate into benefits or not. So at present, these are all clinical trials. So we need more data. Once we have more data, then only we can advocate. If you look at the data in terms of the hard endpoints, vitamin A alone doesn't really work. The study which has shown is a combination of vitamin E plus pioglitazone to be of better benefit. So I would not advocate at present as a routine use. Yes, for clinical trials, definitely yes.
And what's your take on saroglitazone?
I showed you very clear data. The data is only non-histology data which has been published. The data on which DCGI has clearance has not been published as yet in print. That is only presented as an abstract. So we need really more data, and what I know is probably multiple clinical trials, including histological endpoints, are being done in the US. I think we look forward to that data. I'm not sure we're not doing any histological studies in India on saroglitazone, which I am not aware of. But that data is not published in print.
Yeah, we are not doing, most of us are not doing biopsies at all, in fact. That was the debate also.
That's very true, but sir, most regulatory authorities like the FDA needs that data, and I'm sure Professor Sanyal is here who would give us a better perspective on how a drug can be cleared, but then we don't have that data in print as yet.
Arun?
So I actually had a question for GC. So Gordas, that is, there's a different GC, which anyway, never mind. One thing you didn't mention was mental health. You know, everything in life is context specific. And I have a general problem with saying, follow this diet or that diet. The same nutrients, when your entire sympathetic nervous system is turned on and you have very high cortisol levels, your catecholamines are high, is going to have a very different biochemical response nutritionally than when you are not turned on from a autonomic perspective. So, you know, did you get a chance? You've been thinking about this for a long time. I'm sure you've thought about how to deal with the underlying behavioral elements, depression, anxiety, PTSD, those kind of things, and what's your practical approach to dealing with that?
A lovely question, but you know, this is, I was a bit ashamed to talk about it to hepatology, you know, researchers in hepatology like you, because this comes within the realm of clinical medicine, little bit of, shall we say, public health and so on. I'll tell you what intrigues me. There are two parts of the world where fatty liver disease is very uncommon. Okay, so they're called the blue zones. So there were 5 of them, and the last one to come in has been Singapore. What's the difference? The difference is the earlier 5 zones, they were very ritualistic. They had a traditional pattern of eating and fasting and walking. So anybody who was born there and decided to stay there had to follow that, and they did not have most of the metabolic disorders. What is interesting about Singapore is that being an educated society, it qualified to come in as a blue zone because of policy decisions. The policy decisions were so well done. So if you don't own a car, the government gives you a certain amount of money. If you walk to your office and back, you know, you get some bonus money. So similarly, you know, I think that they have manipulated the whole conditioning to such way that it's conducive to positive health. In India, you know, unfortunately, we are neither here nor there. So those who had the benefit of earning a little bit, we went into the other type, you know, eating more and exercising less. On the other hand, the people who stayed back and did the manual work probably didn't get fatty liver disease. But that's not what one would like to advocate. So that's on the part of conditioning. With regard to mental health, my problem has been that yes, a lot of people require intense motivation, and it has to be sustained motivation. So when these patients were following up with me for over a year, I used to meet them almost once in 2 weeks to keep them motivated. Motivation is to keep them going. Once you give up, they tend to lapse. And people who are in very fluctuating mood status, you know, especially depression, a lot of antidepressants, I see that, you know, people put on a huge amount of weight.
No, GC, that's not what I was talking about at all. Motivation is one thing, but underlying psychopathology that leads to a stress state, mental stress state, where your entire cortisol system is turned on. You're going to have a very different physiologic response to that no matter what you eat. So I think making a broad statement about diet is a little problematic without taking into consideration the background of mental health in the setting. That's my point.
I would agree with you. In fact, Arun, if you remember your days in Hostel 7, before the exams, some people put on weight, whereas some people lost weight. And that's a perfect example of how you react to stress and your eating behavior. But we haven't studied it, to be honest.
Maybe we can have the last quick question and answer, quick answer.
Yeah, this is a response to GC. We have published 2 papers. One was in 2020, that was on exercise, where we showed that 2/3 of our patients fatty liver disappeared. And at that time, we didn't look at fibrosis. We were looking at fatty liver. They didn't have fatty liver after the completion of the exercise schedule. But recently, this year, we have published a lifestyle intervention paper in which we showed that 1 year study, 85% of the patients had reduction in weight, and 50%, half of them had a 2-point reduction on RFE. So 2-point reduction. And this is a real life study. And I thought you would touch upon that. So I just thought I should mention that.
Well, thank you very much. I think we're out of the time for the session. So thanks again for all the great talks. Thank you.
Thank you, chairpersons, and thank you, speakers. Can I request you for the center of the stage for a group picture?